A very good morning to all of you. So the topic of my presentation is Aumolertinib plus Apatinib versus Aumolertinib as a first-line treatment in patients with EGFR mutation-positive, locally advanced or metastatic non-small lung cancer. And with the background, we know that the first-line treatment for such patients are third-generation TKI. But we know it has limitation, resistance is inevitable. So the idea is how to make the response more robust and more sustainable. We want to combine an EGFR TKI with an anti-angiogenic agent which can perhaps potentiate and with a synergistic effect can make the effect more robust. So that was the basic idea when we started with the attention study. So we have been talking about osimertinib, something beyond that. So here we talk about aumolertinib, which is again a third generation TKI, and the best thing is that we have a trial head-on with gefitinib versus aumolertinib, showing the effectiveness of aumolertinib. The baseline characteristics were well matched, and it showed that there was an advantage in the progression-free survival of 19.3 versus 9.3 with gefitinib. And this advantage was shown across all subgroups, irrespective of the smoking status, age, sex, performance status, and also across whether the patient was 19-del mutated or L858R mutation, and whether the patient had a CNS metastasis or whether the patient did not have. And the toxicity was well accepted, and the conclusion was that aumolertinib may be warranted as the first-line treatment. So not only for DEL19 and L858R, also for the subgroup of the patient which has the EGFR T790 mutation, the Apollo registration trial confirmed, you see the waterfall plot and the Kaplan-Meier, and the outcome was that Apollo registration confirmed an overall response rate of 68.9%, and also talking about the toxicity as compared to osimertinib, there was less rash and treatment-related diarrhea. So this molecule appeared very, promising. Talking about the anti-EGFR2, that is apatinib, which is again we have papers of apatinib as a monotherapy in non-small lung cancer, and also apatinib in combination with gefitinib, which has shown an advantage in the progression-free survival of 13.7 months versus 10.2 months. So with this background in hand, showing the effectiveness of apatinib as well as aumolertinib, this trial was designed whether to use this aumolertinib plus apatinib versus aumolertinib alone. So this was basically a trial design, and the primary endpoint was to see the progression-free survival, and the secondary endpoint was to see for the overall survival, the overall response rate, and the disease control rate. Now again, the baseline characteristics were well matched, and this is a very important efficacy trial which showed that irrespective of the patient had EGFR mutation, DEL mutation, or L858R or rare mutation, the patient showed an overall response rate of 75% in the combo arm as compared just to 68%. The disease control rate was 100% as compared to 96% with a significant p-value. The patient with having a brain metastasis showed an intracranial response rate of 81% versus just 62% in the alone arm versus a combo arm, and the intracranial disease response rate, disease control rate was also shown to the tune of 100%. Now even for the patient with liver metastasis, the overall response rate was shown to the tune of 63% versus 33%. So this combination molecule of aumolertinib and apatinib showed very promising at the cost of patient had AEs in the terms of thrombocytopenia and hypertension, but that was grade 3. None of the patient had grade 4 or grade 5 treatment-related AEs. So the conclusion was the combination of this new third generation TKI, that is aumolertinib, plus anti-EGFR2 apatinib may provide a more effective and a well-tolerable treatment options compared with the aumolertinib alone for the first-line treatment in EGFR mutated or locally advanced non-small lung cancer. The primary subgroup results may suggest potential advantage of aumolertinib plus apatinib. Now this is again a very interesting paper where aumolertinib high dose is being compared head-on to osimertinib in patients with T790 mutation with brain metastasis. And perhaps in days or years, in months to come, we will be having a more robust molecule with osimertinib, and where we can offer, we will enhance some more better molecules for the patient to offer and have more sustained and more robust response for such locally advanced or metastatic non-small cell lung cancer. So with this, I thank you all for your patience.